Good morning, everyone. It's great to see a full complement of board members here with us for the medical board meeting. I would like to first ask all of the members to turn your cell phones, any devices you have, your computers to silent. For the public, you may notice board members accessing their laptops, phones, or other devices during the meeting. They're using these devices to access board meeting materials that are in electronic format. If you are a member of the media and require assistance or information, please see Erin Bone. Erin, if you could please identify yourself. Thank you. This is an official business meeting of the Medical Board of California, and disruptions of the board's business will not be tolerated. Government Code Section 11126.5 allows the board to remove people who willfully interrupt a meeting and to clear the room if order cannot be restored by removing or muting the disruptive people. We will have a designated time on the agenda for public comment on items not on the agenda, and we will ask for public comment on agenda items. The board welcomes public comments on any item on the agenda, and it is the board's intent to ask for public comments prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please just raise your hand and come forward and you will be recognized. This meeting is also being streamed via WebEx. Individuals attending the meeting remotely via WebEx will have an opportunity to provide public comment and will be assisted by the host, who will be facilitating the WebEx meeting. During each agenda item, the host moderating this WebEx event will activate the hand raising and Q&A features of WebEx and will ask anyone wishing to make a public comment to indicate so by raising their hand or entering yes in the Q&A window. The host will then call on individuals who indicated they wish to make public comments by the name provided by the individual, which may be a pseudonym. When called upon, the host will unmute the microphone of the individual, and they will have 3 minutes to make their public comment. But this time period may be reduced depending on the number of people who wish to speak, so that more people may be heard. The host will audibly announce when 30 seconds remain to conclude the public comment. And after the individual's time for public comment has lapsed, the individual will be placed back on mute. Only one public comment per agenda item is allowed per attendee. During agenda item 2, public comments on items not on the agenda, the board has limited the total public comment period for individuals to 40 minutes. Therefore, after 40 minutes, no further comments will be accepted. During public comment on any other agenda item, 20 minutes will be allowed for the comment period. And after 20 minutes, no further comments will be accepted. Each person, again, will be limited to 3 minutes per agenda item. I would like to remind all speakers to please stay on topic and keep your comments to the allotted time or less. Today's meeting will be run in accordance with the Open Meeting Act as required by law, and we do plan to end today's meeting by 5 p.m. For the board members, you do need to speak into the microphone. We've been having some audio troubles, so if you can just make sure to bring the microphone close to you when you wish to speak. So I would like to officially call this meeting of the Medical Board of California to order at 11:05 a.m. Ms. Struther, please call the roll.
Dr. Ayala Rodriguez.
Here.
Dr. Bolat.
Here.
Ms. Chung.
I'm here.
Dr. Helzer.
Here.
Ms. Mitchell.
Here.
Dr. Mahmood.
Yes.
Ms. Renke. Here. Dr. Thorpe.
Here.
Ms. Torres.
Present.
Dr. Sai.
Here.
Mr. Watkins.
Present.
Dr. Yip.
Here.
Ms. Lawson.
Here. Thank you, everyone. The entire board is present, so we have a quorum present. Again, I would like to remind the members that we'll be taking a roll call vote on all action items. So moving right along, agenda item 2, public comments on items not on the agenda. Before I ask for public comments, I would like to ask individuals planning to make comments to not discuss pending complaints, pending licensing applications, or pending disciplinary actions that may come before the board for a decision. Such discussions are considered ex parte communications, as they could provide information to the members that is outside of the record in violation of the Administrative Procedure Act. Therefore, such discussions could create a conflict and lead to a board decision being challenged in Superior Court. The board can receive comments regarding the board's processes in general, but it cannot receive comments on specific case circumstances where the decision is still pending. In addition, the board requests the public to address the board as a whole and not individual members. Again, please be aware that public comment during this agenda item should provide information to the board members and is not a discussion between the board members and the public. The only action board members can take is to listen to comments and decide whether they'd like a future agenda item on the topic. No other action can be taken on the item at this meeting. Though this may seem at times like the board members are not being responsive, following these guidelines is critical to ensure the rules of the Open Meeting Act are followed and to avoid compromising the speaker's goals or the board's mission. If you'd like to comment on an agenda item, please do wait until we get to that agenda item. Comments at this time are only for items that are not on the board's agenda. And please, again, limit your comments to 3 minutes. Are there any comments from those present in the hearing room? Welcome.
Good morning. I'm Michelle Montserrat Ramos, and I'm with Consumer Watchdog. I'm here to introduce myself to the new board members. I became a patient advocate many years ago, following the death of my husband-to-be, Lloyd Montserrat. Lloyd entered a Los Angeles hospital for elective surgery and never walked out again. His doctor gave me no cause for his death. The pathologist I hired stated that Lloyd died from a botched surgery, untreated infection, and septic shock. I was left to do my own investigation and later discovered that Lloyd's doctor had a long arrest record, all while he held a license to practice medicine in California. He'd been arrested for felony possession of crack cocaine and multiple arrests for prostitution. I began coming to medical board meetings to learn how the enforcement process works in order to file the most effective complaint possible. But that didn't seem to matter. When I filed my death complaint on behalf of Lloyd, my complaint was closed at the Central Complaint Unit with no interview and no input from me. I have told you many times that all you had to do was investigate Lloyd's death. Had you investigated his death and offered some form of disciplinary action, I would have walked away. Now I work with families across the state of California to help them navigate this complex system, to work on policy change and legislation and maternal mortality, and to keep you focused on consumer protection. Had you just investigated my complaint, I wouldn't have the family here today and the families that will be joining us tomorrow in person and on WebEx. Think about it. You wouldn't have had to fight for the past number of years over these pesky uniform standards for substance abusing licensees. They came to be over a diversion hearing when I had the opportunity to speak to the committee. Please understand, Lloyd and all of our families that we have lost tragically due to gross negligence by a physician in a hospital were not just medical record numbers. They were real people that were loved and honored and contributed to the state. Lloyd was a political leader. There's a library dedicated in his memory. There's a jogging path dedicated to him. There's a transitional home for foster youth aged out of the system named after Lloyd. Please remember this when you hear these families speak. Please remember this when you vote on these issues that are critical to consumer protection. Please remember us when you are with your family this holiday season. As you know, I will be trimming Lloyd's Christmas tree at his gravesite while you are enjoying your family. Remember this when you make these critical decisions that affect every aspect of our family's care. Thank you.
Thank you, Michelle. Are there any other public comments in the room?
Good morning, members of the board. Thank you guys for your time today. We are the family of Snyder Lopez. This is my mother, Mercedes. That is my father, David. I am the brother, Jesus. We are from Gardena and we are volunteers from Consumer Watchdog. My son died tragically and brutally in a local hospital last month. I am here for you to see the face of my parents that have not only lost our children but helplessly watched them tortured by doctors who had no answers and claimed they had no idea why my son was dying. I was referred to this hospital by our pediatrician when my son was diagnosed with leukemia. He underwent treatment there, and it was effective. He was in remission. I can't tell you what a relief it was to see my son back to being a happy 13-year-old boy, skateboarding, camping, off-roading, and enjoying his life again. When I took him back to the hospital for follow-up appointments, I was told that he needed a bone marrow transplant immediately or he would die in 3 months. I questioned this. My son had just been in remission. My son was healthy again. He was strong. He was back to going to school activities. He was back to his regular life. I was pressured by the doctor and the social worker that my son would die in 3 months if I did not agree to a bone marrow transplant immediately. I was given a consent form, but it was in English. I had no idea what I was signing, and I was not allowed to take a picture of it to send it to my husband and to my daughter, who could tell me what I was signing. These forms are available in Spanish. Why was I only given an informed consent form in English? This is the beginning of the end for my precious son. Immediately after his bone marrow transplant, he began to have complications. My son started to have very high fevers, but his doctor said he did not have an infection. They claimed that they couldn't find anything wrong with him, and they couldn't figure out why he was suffering from fevers. His doctor placed him in a separate room thinking my son had an infectious disease, but never caught an infectious disease specialist. My son suffered so much right before my eyes. When his doctors told me that they didn't know what to do, I pleaded for a transfer to another hospital that could provide a higher level of care for my son, but I was told no over and over again. My son died last month. He suffered so much, I was told that this board is the next step in getting answers and trying to stop the extreme negligent care that our children are receiving and enduring by these doctors. My brother died a very tragic death. All his skin was peeling from his body. My brother went in with hope that he was going to be able to come out again. He had planned to invite the nurses, his favorite nurse, his favorite doctor, the medical staff that he helped, that he thought that were there to help him. He went in with hope, just the way that we did, but he did not walk out. We have been going crazy during the last month, going through hundreds of pages of medical records without really understanding, because we're not doctors. We're here to plead for help and for justice for my brother Snyder Lopez, for all the negligences that we have found in the medical records. Thank you for your time. She wants to
Thank
add
you.
one last thing.
Todos tienen hijos.
All of you guys have kids.
Nadie merece que su hijo muera cayéndose de su carne.
Nobody deserves to see their son's skin falling off
Como murió
his
Snyder,
body the way that my brother died,
desangrándose,
bleeding out,
sin ver un medicamento para el dolor,
without any doctor being able to find any medicine to take away his pain,
pidiendo ayuda que me cambie
begging
para
for
otros
somebody to
hospitales.
help us to send us to a different hospital to get some answers.
Toda la ayuda para mi hijo. Nadie merece morir
Nobody helped him.
como murió.
Nobody deserves to die the way that my brother died.
Mañana les voy a traer las
Tomorrow we will bring pictures to show you guys
evidencia de cómo
the
entró
evidence
Snyder
of
a
how
la
my
vida.
brother went in and how he came out with nobody willing to help him, nobody willing to give answers.
Evidencia de cómo murió desangrado y descarnado mi hijo.
The way that he was sitting in his stool for hours with nobody cleaning him inside the hospital. The way that nobody treated his skin and that my parents had to,
Evidencia de cómo
They had
estaba
to-
en un estado insalubre en el ICU con tantas infecciones.
nobody was helping him in the ICU.
¿Por qué puros niños latinos
Why is the only Hispanic children
están muriendo?
are dying in the hospital?
Habemos 10 madres que nos dijeron lo mismo.
There's 10 other mothers that would say the same thing. Your son has 3 months to live and you have to choose right now or it's going to be too
No
late.
tenemos papeles.
None of us speak English.
Que una célula que le
That
salió
one cell that came out in his body
en
was the
una
reason
célula
why they
que
had to do a
mandaron
transplant.
fuera de la ciudad. Si no hacíamos un trasplante,
If we
moriría
didn't do it
en
now,
3 meses.
he would die in 3 months.
Es una mafia interna monetaria.
It's
que
an
estamos
internal
haciendo.
mafia that are just collecting money.
Mañana conocerán las historias de las mamás.
Tomorrow you will know the stories of the other mothers that have
que
tragically
usaron
lost their
el
children,
mismo sistema de engaño,
that they use the same system of lies,
que una célula que
that
salió
one cell popped out of the millions,
los iba a matar en
and that
3
they would die in
meses.
3 months if they didn't act now.
Y murieron de la peor
And they
manera
died a
más
horrible
horrible
death,
que pueda
just like my
pensar.
brother, that no criminal deserves.
Gracias y
Thank you guys for your time.
que tomen en cuenta la historia de cada mamá que estamos sufriendo este dolor. Por favor. Gracias.
Thank you for your public comment. Are there other commenters in the room? Okay, Sean, let's go to the WebEx.
Hello, can you hear me? Okay, thank you. Good morning. My name is Marion Hollingsworth, and I'm a patient safety advocate. I've been an advocate since my father became the victim of deliberate medical harm in 2009, and I've been following this medical board closely since 2014. I'd like to welcome the new members of this board, and I want to impress on all of you the importance of taking your responsibilities seriously. The most important thing you can do is to listen to us when we say a doctor is dangerous. My father died because he was deliberately given antipsychotic drugs in a hospital and nursing home without any prior assessment or informed consent. Consent forms were falsified, even a DNR. One doctor just got a reprimand and the other was let off. After the second case was dismissed by this board, I appealed and I pointed out if nothing was done to control this doctor, other patients could die. Just 6 weeks after my appeal, the doctor overdosed a patient by giving him 480 Vicodin. If this board had listened to me the first time, maybe this doctor would have been disciplined for my father's death, and maybe that second man wouldn't have died. If you want to protect patients according to the board's mission statement, you must take the disciplinary guidelines seriously. All too often, these guidelines are totally ignored. Do you know there's a surgeon in the San Diego area that just got 4 years probation for 3 patient deaths? Not even the minimum discipline. There's a former CMA president who paid a multi-million-dollar settlement for a botched epidural resulting in permanent harm, and this board just gave him a citation. And there's a doctor who worked at another board member's surgical clinic and got just a reprimand for a DUI of 0.29. It's not just sad, it's pathetic. If you really want to, if you really want to protect the public, you have to follow your own guidelines. Finally, I'd like to address the issue of board transparency and ask for an agenda item on how decisions are made public besides just being posted quietly on a doctor's profile page. You used to tweet out every decision and email a list of the recent cases, but you rarely email the public anymore except around the time of these quarterly board meetings. A reporter even asked me about this recently. At this last meeting, I brought this lack of transparency up and was told by Mr. Varghese that we needed to check the Excel list, putting the board in ball in our court, so to speak. Well, a few people know about this Excel list, and there's no mention of it on the board website. Can you all please decide how you want to inform the public of dangerous doctors and report back to us at the next meeting with an agenda item? As the saying goes, knowledge is power. If you give consumers the power to make their own healthcare decisions, you'll have better results. Thank you.
Hi there, this is Christina Hildebrand. Can you hear me? Great, wonderful. My name's Christina Hildebrand. I'm the founder and president of A Voice for Choice Advocacy. We educate, advocate, and empower people to know their health rights in California. Specific to the medical board, I just wanted to welcome the new board members and thank the old board members for continuing on. I did want to talk about one of the issues that is relevant in our world and our nonprofit is the issue of required vaccines. And we have had a number of patients who have tried to either get transplants or have tried to get medical treatment in hospitals in California that have been denied that treatment because they are not fully vaccinated, whether that's with childhood vaccines, the COVID vaccine, the flu vaccine, and they are being required to get those vaccines right before their surgery or their treatment. And we want choice for everyone to have vaccines. We are not against vaccines, but at the same time, vaccines come with side effects, and they come with, there's pages of package inserts, and the patients are not being allowed to make an informed decision on that. They are not being required to give informed consent. They are being forced. If they refuse a vaccine, just one vaccine and a vaccine that isn't necessarily necessary for their treatment, or that they are very unlikely to be subject to. For example, let's take polio. Polio is not in the United States, but they are required to take a slew of vaccines before they get these medical treatments. They're happy to take them after their medical treatment, after they have their immune system is back up, but they are being required to do it beforehand. And I would really ask the medical board to come out with some recommendations and not forcing patients to take vaccines when they are in such a weak state. There have been a number of patients that have taken the vaccines and had adverse reactions because they've reacted with other medications that they've been given. And there's a girl in UC Irvine that had a terrible reaction and lost all of her skin, had bruises everywhere as a vaccine reaction because she was required to take 3 vaccines. I ask you to do some research and to not to come up with recommendations that don't require hospitals to require vaccines prior to medical treatment. I appreciate your time. Thank you.
Next here we have Rob Gordon. Rob, you should be receiving that front. And Rob, just it's a limitation of WebEx that we cannot have attendees' cameras active.
Are you able to hear me?
Yeah, Rob, please go ahead. Rob, we can hear you. Any requests, Rob?
Are you able to hear me now? Yeah, thank you. My name is Rob Gordon, and more than 4 years ago in July of 2020, I had my successful diagnosis and treatment for ADHD overturned by a woman just out of med school, a psychiatrist named Derica Aragon Maligros, who was screaming about me about cannabis in a brief online meeting. I'd never met her before, that 10-minute online meeting, and my life changed forever. Because I made the mistake of admitting rare but occasional use of marijuana, I was immediately given the diagnosis of cannabis use disorder, and my ADHD diagnosis was overturned, and I was instead classified as a depressed substance user. My ADHD diagnosis had been given to me by Dr. Edward Urbe, who is an honest and competent professional who was recently charged by the medical board with gross negligence for his correct diagnosis and successful treatment of my ADHD. Because the medical board may try to claim I'm not allowed to make comments that are under litigation, even though the hearing is over,
Gordon?
I'm just going to talk about a few policy issues here, especially the
John, can you
investigations you guys
Let him
conducted.
know he has to refrain from talking about the pending matter.
Had to put him on mute. Should I open it back up? Robin, sending that request again, you'd have to accept it again in order to.
Yeah, I said I was just going to talk about policy issues. Am I allowed to speak here?
It's fine for you to discuss policy issues.
Okay, I'll try to limit that. The first thing I want to first of all, my situation is not as horrible as some of the participants here, but I think it's important for everybody to know that you do not do real investigations. They're fake investigations, and I make that claim for a very simple reason. Nobody ever bothers to pick up the telephone to call you or talk to you. I'm not going to talk about the specific issue, except that by your estimates, the investigation so far has cost about $70,000. That's just a fraction of it. You didn't count everything, and that's not including everyone else's time. That's just yours. but nobody picked up the phone. You're not even a real person. I have come to the conclusion that you are not protecting the public at all. You're protecting physicians. You can't even really say you're protecting the profession. You're only making insurmountable legal barriers. You have to be incredibly wealthy to even have any kind of legal approach to this. I've spent 4 years of my life. A huge amount of public money has been spent, and nobody has bothered to listen to my side of the story. It's almost like you're not even a person. So now I'm 70 years old, almost 71. I was eventually able to get just the medication management part of my ADHD restored by going to an online physician in Florida, who was fine. He's a great guy. But I no longer have medical care. I lost everything because of a pathological liar in your profession. Again, he's not a part of the litigation, so I'm not saying anything.
I saw a call-in user only join. Just to mention that if you're on a call-in only line, you can press *3 to toggle raising your hand. Just to make sure they got an opportunity. I'm not seeing additional requests.
Thank you, Sean, and thank you to all the public commenters on WebEx. I'll just do one more check. Are there any public comments from anyone in the room? Okay, with that, we will move on to agenda item 3, approval. Nope. Just kidding.
Last second request there.
Okay.
Molly Goddard, your line should be.
You guys hear me? Okay, excellent. Good morning. I'd like to welcome the new board members for sure. And I have a request of them. I've made this previously, but I think I'm going to do it every quarter. So you guys will have to get used to it. But I would really appreciate it if the new board members would go back and view the video record of the May 2023 board meeting where they unanimously approved their new opioid prescribing guidelines. I think it's imperative that the new players on the board get a little history lesson on the process that we went through and the actions that were promised. One of the actions was a very aggressive rollout of those guidelines. I'm here to tell you that's not happened yet, and I'm really anxious to see that take place. So welcome, and I really do request that you look at that video. Thank you.
Thanks, Sean. Right now, we'll move on to agenda item 3, which is approval of the minutes from the last board meeting. And just a reminder for board members and for the public, the minutes are a summary and a record of the votes that take place at the board meetings. But the full recorded meeting is always posted via video on the board's website, and there are links in the minutes as well to the videos. Members, does anyone have corrections to the August 22nd, 23rd, 2024 board meeting minutes? All right, may I have a motion to approve the August 22nd and 23rd, 2024 board meeting minutes as submitted?
I move to accept.
Thanks. We have a motion from Dr. Helzer, and it sounds like a second from Dr. Thorpe. Are there, I'll move to public comments. Are there any public comments on the minutes from those in the hearing room? Sean, can you go to the WebEx? Thanks, Sean. All right, we'll bring that back to the board. Any last minute changes? Any discussion? All right, Ms. Struther, please call the roll.
Dr. Ayala Rodriguez,
Yes.
Dr. Bolat,
Yes.
Ms. Chung,
Yes.
Dr. Helzer,
Yes.
Ms. Mitchell,
I'm going to abstain.
Dr. Mahmood,
Yes.
Miss Remke,
Abstain.
Dr. Thorpe,
Yes.
Miss Torres,
Yes.
Dr. Sy,
Yes.
Mr. Watkins, Dr. Yip,
Yes.
Miss Lawson.
Yes. All right, the August 22nd and 23rd, 2024 board meeting minutes are approved. We're now moving on to agenda item 4, which is the president's report. And I have just a very brief report. I wanted to again welcome everyone to today's meeting, and I especially wanted to welcome our new members to the board. We are thrilled to have you join us and to bring your unique perspectives to our important work. It really is terrific to have a full board after, I think, many years of us not having all of the positions filled. So we're pleased for that. I'd like to specifically welcome our newest member, Jody Remke, to the board. And I also wanted to welcome Wendy Mitchell to your first official board meeting, although you were appointed right before our August board meeting. As we look ahead, I am filled with optimism about the initiatives that we have on our plate this year. I want to extend a special thank you to Dr. Yip and to Ms. Torres for leading our task force effort regarding the Physician Health and Wellness Program that we will discuss in more detail tomorrow. These efforts are critical to fulfilling our mission, and I'm confident in the collective strength of this board to help us navigate the road ahead. I will say that we live in truly interesting times, and I have no doubt that we will face new challenges over the next couple of years. Some of those challenges we'll be able to anticipate, and I suspect that there are others that will take us by surprise, as we've experienced in the past. But together, as a team of dedicated board members and just a terrific, top-notch staff, thank you to all of our staff for everything you do for us every day. I think that we're well-equipped to meet these challenges head-on. So just my gratitude and thanks. It's a privilege to work alongside all of you in service to the people of California. And I would like to offer Ms. Remke and Ms. Mitchell just the opportunity to introduce yourselves briefly before we move along on the agenda, if you'd like.
Sure, I'll start. My name is Wendy Mitchell. It's an honor to be a part of this board. This is the third regulatory board that I've been participated in. So the process is familiar. The issue areas, I'm still getting up to speed, so I look forward to that. I live in Los Angeles and DC, and I have my own consulting business, and then I also have a firm that is called Empower Her Mentoring that mentors younger women in politics and public policy. So it's an honor to be here, and I appreciate Governor Newsom appointing me to this board. Look forward to working with you.
Thank you. We're glad to have you. Ms. Remke.
Good afternoon. My name is Jody Remke. I'm also excited to be here and do this important work. I retired from state service 2 years ago, and prior to that, I spent many years being a judicial officer, and one of those areas was in the regulation and discipline of attorneys for the state of California. So there is a crossover there in the process, and ethics is so important in all these professions, so I'm excited to be here and continue your work of protecting the public. Thank you.
Thank you. We're glad to have both of you. All right. Are there any comments, questions about the president's report from members? How about from the public in the room? Any comments? All right, Sean, let's go to WebEx. Okay, thanks. Bring it back to the board, and we will move on to agenda item 5, which is board member communications with interested parties. And again, a reminder to members, this is an opportunity for you to disclose any communications you've had with interested parties relating to agenda items. It looks like Dr. Thorpe, you may have the first communication to report.
Thank you, Madam President. I would just like to report, I had a meeting with Mr. Verghese on September 23rd with the advocates for chronic pain management, Mr. Goddard, Mr. Lawhern, Ms. Irving and another lady, Kristen, and discussed their challenges with obtaining appropriate medication for chronic pain, especially chronic intractable pain, and the institutional barriers for that. Specifically, speaking about the recent injunction against the pharmaceutical companies and the pharmaceutical distributors, especially Cardinal Health and McKesson, and there's a third one, I can't remember the name of it, where it's an extremely challenging problem. I also attended the Board of Pharmacy meeting where Cardinal Health came and made a presentation and made a comment, not representing the board, but just representing myself as a concerned physician about this particular issue. And I would, there is some move to try to meet with the Board of Pharmacy, although it's a much bigger problem. I don't want to take the time here to take the board's time to discuss it, although I think it's extremely important to recognize that every pharmacy is being given a limit of medication that they don't know what the limits are. They have no way to discover the limit. They have no way to figure out what the formula is for their limit. All they find out is that they've exceeded their limit. Their supply of medication is not given to them.
Forgive me, I'm afraid that we're getting off of the agenda item.
Oh,
It's going
okay.
too far.
Well, it's a report of the Board of Pharmacy meeting. Anyway, there is some activity. We're trying to figure out a way to work with the pharmacy board to address this in a therapeutic way. Thank you.
Thanks, Dr. Thorpe. Do any other members have communications to report? Dr. Mahmood?
Yeah, I had conversation with several physicians trying to get some people on expert witness, some different specialties, and I'll refer appropriate names to executive director.
Any other communications to report?
I do.
Oh, Dr. Ballant?
Yeah, thank you very much. Yes, I met with our director of licensing, and I was appreciative of the meeting with the DIO, designated institutional officer at UCLA, David Geffen School of Medicine, to clarify the PTLs. Thank you.
Great, thank you. Any other communications to report? And again, as I usually report, I continue to receive frequent inbound communication from members of the public and from physicians, all of which I usually forward to staff for a response. Okay, I guess we have comments again. Any comments in the room? How about on WebEx?
My name is Maisha Draves. I'm a physician in family medicine at Kaiser Permanente. And Kaiser Permanente seeks to partner with the medical board and the Board of Pharmacy to examine the impact of the National Opioid Settlement Injunctive Relief, the national settlement, on distributors, pharmacies, and most importantly, patients. Our goal is to really ensure the safe care, evidence-based care of our patients, including essential medicine when needed. And we seek to work with both boards and other stakeholders to better understand the unintended consequences of the national settlement that could impact the safety, the quality care, the access into care. We encourage both boards to hold robust discussions in the future and meetings to discuss the patient challenges, accessing needed medication, and even medications needed for opioid use disorders such as buprenorphine. And we at Kaiser Permanente seek that ourselves and other healthcare systems that are currently experiencing this partner with you. And we look forward to supporting this effort further. Thank you.
Good morning again. I didn't introduce myself to the rest of the folks, but I'm a 45-year licensed civil engineer in the state of California, and I'm an advocate for my wife, and I've become an advocate for many others who are suffering from undertreated, severe, intractable pain. I just wanted to thank Dr. Thorpe and Mr. Varghese for meeting with myself and the folks he listed. The fourth person was Kristen Ogden, who spoke before the board many times during the process of updating the opioid prescribing guidelines. I strongly want to endorse the comments of the prior speaker, and I'll save the rest of my spiel for tomorrow, future agenda item. Thank you.
My name is Pat Irving, and I'm an RN with 40 years experience and risk and patient safety at Kaiser Permanente. I am retired now. However, I stay very involved in both patient safety and chronic pain management. I would like to emphasize what the other speakers have, that this injunction is not a small problem. It is a broad institutional piece of mechanism that has gotten into our healthcare system that denies access of patients to their medications. It also denies physicians the ability to do their clinical decision making. So this injunction puts a stop for physicians being able to make the medical decisions that they need to make. Of warning, there is a sentence in the injunction that says that the injunction writes and creates reports to search for suspicious physicians. Okay, that is directly out of the injunction. So no physician is safe from this. It's not just about patients. This injunction is looking to go after and mark physicians. It cannot stand. We must band together with the pharmacy board and interested groups like Kaiser Permanente and defeat this injunction. Thank you so very much.
Thank you, Sean, and thank you to the commenters. We will move on to agenda item 6, third annual progress report on the licensed physicians from Mexico pilot program. And for this agenda item, we are very pleased to have Dr. Sergio Aguilar Gaxiola join us again to present this report. Among many accomplishments, Dr. Aguilar Gaxiola is the founding director of the Center for Reducing Health Disparities at the UC Davis School of Medicine. And Dr. Aguilar Gaxiola, we are looking forward to hearing your report.
Well, thank you so much, Chairwoman, and it's my pleasure to be here with you. This is the third report that I have presented to you, and my team and I are very grateful for that. So I'm going to share my screen, hoping that technology is going to be of help. Can you see? Okay, and can you hear me well as well? Excellent. Well, the project that I will be presenting on is called the Licensed Physicians from Mexico Pilot Program. The acronym is LPMPP. And I'm going to present a little bit of a background because there are new board members that I would like to give a little bit of a context about this particular project. So I'm going to start with a little background of the Assembly Bill 1045. Specifically is the Licensed Physicians from Mexico pilot program. And this goes back over 2 decades. In 2002, the then governor approved Bill 1045. And the project is mandated by the Business and Professions Code, Section 853 of the Department of Consumer Affairs. And what it does is that in California, there are 3-year licenses for, this project was for 30 physicians, highly qualified physicians from Mexico that are allowed to practice in nonprofit community health centers, and I'll tell you a little bit more about them. And this happens in medically underserved areas, primarily in the rural areas. The LP MPP project also tries to address a national physician shortage, as I mentioned, from qualified doctors from Mexico, that really meet the cultural linguistic needs, especially of those populations that they are serving. And you will see in a minute, I have a slide in which I refer to the 4 fairly qualified health centers, community health centers, that are having these physicians. A little bit of background in terms of the physicians workforce shortage. And I have a few slides that will illustrate this point, that the primary care physicians workforce in California is unevenly distributed. Another one is that some primary care physicians do not accept medical patients. Primary care physicians tend not to be racially and ethnically and linguistically diverse in comparison to California's population. Also, there is already a good proportion of physicians that are retired, and this will continue to happen within the next decade, especially in rural areas. COVID put a lot of stress on those physicians, and that has prompted even more retirements. The forecast is, in terms of creating a workforce of physicians, is that there is an insufficient number of primary care physicians that will enter the workplace to replace those who retire, as I have a slide that illustrates that point. Just to give you a sense, this was the active patient care primary care physicians by region in California, going back to 2015. And I'm highlighting 2 regions, specifically the San Joaquin Valley and the Inland Empire, primarily rural areas. And the proportion of physicians in those areas is significantly lower than, for example, in the greater Bay Area. This is back in 2015. This is 220, and it is basically the same numbers. And what you have here is, primary care physicians and also the specialists in the turquoise color. Basically, not much progress was made in those 5 years. And there is no indications, even though there is no data that I was able to find that is more recent than that significant changes have happened since then. These are the places, specific counties, where the 4 fairly qualified health centers are located. One is in Monterey County, in Salinas specifically, Clínicas de Salud del Valle de Salinas. The other one is in San Benito County, the San Benito Health Foundation. The other one is in Tulare County, it's called Altura. And the other one, while the other 3 are rural, the last one, Altamed, is located in a urban area in the LA area. But nonetheless, they are seeing populations that otherwise it would be difficult for these populations to have access to care. just to illustrate the point that I made about Medi-Cal, if medical patients being seen by physicians, the bars that I'm highlighting illustrate that primary care physicians, those who have Medi-Cal and also Medicare, not to be seen at the same rates as those with private insurance. Of course, those who are uninsured are seen even less. And these are just to give you a sense about the significant disparities between certain physician groups by race and ethnicity in proportion to the California population. And I'm highlighting the MDs, is that in the case of Latinos, there is a tremendous disproportion of about 77% of the physician workforce in California are Latinos, whereas now it is actually 4.3%, which are Latino. With African Americans, the disparities is not as profound, but it's still, there is a disparity in the representation of African American physicians. Back in 2015, it was about 4%. Not much changes had been made, whereas in the California population, they represent 6%. I don't know if you're familiar with this report. This was a very important report that was released back in 2019. It's called that came out of the California Future Health Workforce Commission. And this was work for 18 months, actually. And it was led by, at that time, Janet Napolitano, who was the president of the UC system, and Lloyd Dean, who was with Dignity Health at that time. And the things that I want to highlight are the ones that are the bolded text that says that California's primary care physician shortage is insufficient numbers of physicians completing residency training in primary care to replace those who retired. For example, California ranks 32 in the nation at 9.5 primary care residents per 100,000 population, compared to New York, for example, and many other states. Importantly, California will need to graduate an estimated 337 additional primary care residents per year from 2025 to 2030, which is an increase of 20%, to alleviate the current and projected shortages. But how is that looking like? Once again, this is data that goes back to 2018, but not much changes have been made. And what I want to highlight here is that from 2016, 17, and 18, the number of MDs, for example, didn't increase much. Actually, there was a little decrease in 2018, and a little bit of an increase in DOs as well. So that is of critical importance to keep in mind. I was unable to include some slides about the disproportion of physicians who are Spanish speakers, for example, and by region, but there is also an uneven distribution of that as well. Now, I'll tell you what this project is about. In UC Davis, the Center for Reducing Health Disparities at UC Davis, had been conducted this evaluation, independent evaluation of the LPMPP project since it began. And in the statute of AB 1045, there are 6 measures that are identified, or metrics that are identified, that measure what you see on the slide, from quality of care, adaptability of physicians, the impact on working and administrative environment, and response and approval by patients. This is the patient experience. a metric about the impact on cultural linguistic services, and also the impact on limited English-speaking patient encounters. There is a seventh consideration that we included, which is a recommendation on whether the program should be continued, expanded, altered, or terminated, which has been one of the charges that we have as independent evaluators of this program. This is a very busy slide, but what I want to call your attention to is that there are three buckets, basically, in terms of the instruments, and that are related to outcomes. One is patient outcomes, as you can see here, physician outcomes, and then organizational and clinic outcomes. And if you pay close attention to some of the specifics about these three boxes, is that, for example, in patient outcomes, it taps into quality of care, and there are some specific information about that. On physicians' outcome, the adaptability of providers, and in organizational and clinical outcomes, administrative and working environment, and delivery of cultural linguistically appropriate services as well, and encounters by limited English speaking patients. This is kind of a framework or a conceptual model that gives you kind of at a glance an idea about what the evaluation has been about. This is another way of representing the framework. And what we have are the patient outcomes, which measures quality of care and also response and approval by patients. These are the instruments specifically within that domain, patient outcomes, and then how often we are doing these evaluations for the life of this project. Under physician outcomes, as you can see here, adaptability of physicians, and then these are the metrics that we are using, the specific instruments, the 360 assessment for staff, knowledge assessment, performance reviews, and chart reviews, and then the time frame, how often we are administering those instruments. And then finally, on the organizational and clinic outcomes, we have, in terms of what is it that we're measuring, delivery of cultural linguistically appropriate services and encounters by limited English-speaking patients. And the instruments that we are using is the 360 assessments for staff, the class organizational assessment for staff as well, and the class organizational assessment for patients, and then the frequency in which we administer those instruments. This is to give you a sense about the specific fairly qualified health centers that we had been working with, and then the number of LP, MPP physicians that they had been working with. Even though 30 physicians were approved to be working in these community health centers, actually only 27 had been working. And that is the distribution that you see here with Clínica de Salud del Valle de Salinas capturing the greater number of Mexican physicians. So let me give you some specific information in terms of the findings. What is it that we have had found in this third annual report? In terms of the 360 assessment for patients specifically, we did the second and final round of data collection. And this is based on the consumer assessment of healthcare providers, clinician and group surveys. And the aim is to get a better understanding of the patient experience and to advance the delivery of safe, patient-centered care. And it addresses 4 domains: accessibility of care, communication with providers, care coordination, and interactions with staff. These are some of the findings, specifically on the 360 assessment for patients. Most of the patients that we tap into were Latinos, not surprisingly, nearly 90%, and most of them are women as well. Some of the findings that, and this is a summary of the findings, is that the patients consistently report positive experiences, and in very high proportions. As you can see on the slide, 82% find appointment access timely. Over 90% are satisfied with the staff interactions. The patients find their providers' explanations clear. The patients feel respected during their visits, and that they also reported that there are challenges with video appointments and ongoing efforts to support patients in navigating these technologies. In terms of the CLAS, the Cultural Linguistically Appropriate Standards Organizational Assessment for Staff, these are some of the things that this assessment measures. We basically completed the 3rd and final round of data collection. Is based on the Communication Climate Assessment Tool. Is an assessment tool created by Dr. Winia from the University of Colorado, and we have been working with them and their colleagues, and we have been using this instrument in other systems of care as well. The assessment covers the extent to which healthcare services provided are effective, equitable, understandable, respectful, quality care, respectful of quality care and services, and also responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. These are some of the findings specifically that we receive out of 1,415 surveys that we sent. There was a 28% response rate. Most of the surveys, those who responded, the staff, a little over 80% are Latinos, and the same percentage are women as well. And some of the patient experiences that they report is that the clinics are making commendable progress in offering culturally and linguistically appropriate services, that clinics are integrating culturally sensitive care into their missions, that clinics are also engaging effectively with their communities, the commitment of clinics to adapting to the diverse needs of their communities, and it encourages further development and training in policies. This is, once again, a summary of the findings. One aspect or one area of the evaluation that we have been very, very much interested in is the qualitative area. What I just presented to you is quantitative, but we are complementing the quantitative with the qualitative. And this is based on in interviews and focus groups. And what they reveal is high levels of satisfaction with the quality of care, highlighting cultural linguistic congruence provided by the Mexican physicians, the LPMPP physicians. Qualitative findings also highlight a positive impact of these physicians and consistent support for program expansion across all groups. And the recommendations have been provided to strengthen the program. This is just to give you a little bit more information about the data collection in this qualitative aspect of the evaluation. And the evaluators that we have been working on, which are experts in this area, qualitative experts, they reach out to clinic staff, administrative staff, in initial and follow-up interviews. They reach out to local providers, LPNPP providers, and patients from the 4 FQHCs that I told you about, and they invited them to participate in interviews and or focus groups. The data collection efforts were tailored specifically to the preference of participants, including whether it was in English or Spanish, on-site or virtual, group or individual, and also the timing in which we conducted the qualitative interviews or focus groups. And you have the numbers there. There were a total of 92 participants. In terms of the administrative staff, you see the number of initial interviews and the follow-up as well, the number of people who participated from the staff, from the local physicians. These are non-LP-MPP providers, and also the LP-MPP providers, and then patients. And these are some of the highlights of the findings from the qualitative work that we did across all the groups. And I'm going to be focusing on four domains. There are other domains that were included as well. For example, the area in terms of impact, what we found is that there was an improved accessibility, increased acceptability, increased patient satisfaction, increased quality of care. And we included for you some quotes, because I think that we think that this is very powerful as well. So this first quote under impact, it reads, "The program in our end has been a complete success, not only from the medical side, administrative side from the clinic, the economical side, but also from the community side. Honestly, people love them." This comes from a non-LP-MPP provider. Another quote, "We've seen massive access, and we've seen massive revenue coming into the clinics as well." Under quality of care, some of the findings is enhanced accessibility, high quality care, cultural linguistic congruence is highly valued by patients. And I'm going to read one of the quotes because of time, the one coming from a patient that says, "I think it's important that they, providers, speak our language, because they bring an interpreter, a nurse, but then you hold back more. Whereas when your doctor speaks your language, you speak directly to them, and it's no longer that there's a third person there." In terms of the recommendations coming from the qualitative interviews and the focus groups, there are two findings that we would like to highlight. One is continue and expand program to larger physicians cohorts, specialty choices, and longer service terms with renewal options. And then the other recommendation is to provide ongoing mental health services for LP-MPP physicians to reduce risk or burnout and isolation. And once again, we have a couple of quotes. One is from an LP-MPP physician. "Yes, we are providers, but we are also migrants. I would suggest holding sessions or something to support us. You sometimes hold yourself up alone. There are times when you have very few people to rely on. Maybe your family is there, but here you don't have someone to give you a hug or to listen to your day, 2 days sometimes. And then from a patient, it should continue and it should be expanded. It is very important for our community. Finally, the last area that I want to highlight is the impact if program is discontinued. We heard quite a bit from those participating in the qualitative interviews and focus groups. Four findings that I want to highlight. One is potential confusion and frustration among patients if the program is discontinued, negative community impact due to reduced access and culturally and linguistically appropriate care, increased provider burnout, and burden on emergency services due to unmet patient needs. You also have a couple of quotes, one from a non-LP MPP provider. If the LP MPP providers leave and there's no replacement for them, economically, it will hurt us a lot too. It's so hard to get providers here. So we have become dependent on the program. We want to bring more providers. And then from a patient, if they take away that program, it would harm us a lot. We have a great need for doctors like them who understand us and who can relate to us. So what is next? I have just a few more slides of what comes next. We have completed the 360 assessment for staff, and we are going to be reporting on Measure 2 and Measure 3A and B. You see what those measures are about. We completed also the 360 assessment for patients, and we will be reporting also on Measure 4, response and approval by patients. We completed the class organizational assessment for staff. We will also report on the final report that we will be issuing on the impact of cultural and linguistic services, based on the class standards. And then finally, that we have completed the class organizational assessment for patients, which is Measure 6 that I alluded to in a previous slide. We have also completed the knowledge assessment, which is based on Measure 2. We have in progress the health effectiveness data and information set, which measures quality of care. We also have in progress the chart reviews and the performance reviews, and we have completed the qualitative data collection of all the measures, that I referred to already. This is the last slide that we are going to be doing some comparisons of round 1 and the final rounds of data collection. You see which are the documents, the instruments that are in progress in terms of collecting data. What's coming next is to submit an interim final report by the end of this year, and then to submit the final evaluation report by March of this coming year. A lot of people that we need to thank. This was has been a complex project that has required a lot of collaboration and cooperation. First, we want to thank the leadership and the patients from the 4 fairly qualified health centers. Also, it's been a pleasure, truly a pleasure, to be working with the medical board. You see the staff, Reggie, Marina, Carrie, Douglas, and Dora. There were others that we worked with in the past. And also, I want to really thank our team out of the Center for Reducing Health Disparities. Iman, Jill Lopez-Rabin, Andrea Nunez, Dr. Miriam Nuno, and Dr. Yuri Garcia. So I'm going to stop here, and I'm going to stop the presentation, and we'll be happy to answer any questions or comments that you have. I welcome them.
Well, thank you, Dr. Aguilar Gaxiola. That was an exciting report to receive about the great work that's going on at the Mexico pilot program. Are there any comments or questions from board members? Dr. Ayala Rodriguez first.
Thank you so much, and thank you for the presentation, Dr. Aguilar Gagiola. This is Dr. Ayala. So I work in a community health center, and many times when we say community health centers or clinics could be a little bit misleading because of the scope of practice. So for example, for my community health center, we go to the hospital, we do newborn rounding, we do specialty consults, we do hospitalist services. Some community health centers have urgent cares and things like that. So is the scope of practice for this program just for outpatient services in community health centers, or does it not have a scope limitation?
No, it is for outpatient, basically, Dr. Ayala. Altamed is one of the largest federally qualified health centers, and they have a I don't want to say a more complete or sophisticated operation, and they work with hospitals and work and have been present in the primarily in the Los Angeles area, but these are rural fairly qualified health centers, and the physicians. Their practice is my understanding is that it's limited to outpatient services.
And for example, for myself, like that was like important to define the scope because, for example, I'm from Bakersfield, and as the more rural you go, the more hybrid you become. So sometimes that the scope is not just outpatient; it's a hybrid mode involving hospital services and things like that. And also because the surveys, I assume that are very, very heavily focusing on the outpatient part. So I just wanted to make sure that there's no inpatient part that has to be evaluated or urgent care part that has to be evaluated because we are evaluating the outpatient piece. But the data presented is great. Thank you.
No, thank you. It's a very important question and important to distinguish as well.
Other questions, comments from board members? Dr. Helzer?
Thank you for your presentation, Dr. Aguilar Gaxiola. You had mentioned in your report you're tracking the HEDIS measures as objective quality of care measures, and I'm wondering if you have any insights from looking at that data so far.
We haven't received that data yet. Tell me your name, I'm sorry.
James Helzer.
Dr. Helzer. Yes, so I wouldn't be able, this is what is in progress, that we are waiting to get the data from the chart reviews and the performance reviews. So I wouldn't be able to give you insights about that at this time.
Thank you.
You're welcome.
Dr. Mahmood and then Dr. Valant.
Thank you so much. It was such a wonderful presentation, and it's really in need of the time. I was wondering, have you also assessed them, their English proficiency, and how's their communication with the staff, other doctors, other physicians, other staff who does not speak Spanish and they need care from them or refer them or get more help? How is their performance on that? I know they probably passed English test, but how's that working?
Yeah, no, thank you for your question. Good to see you again, by the way. Before the physicians are selected, as part of the selection process out of the National Autonomous University of Mexico, Universidad Nacional Autónoma de Mexico, these are very highly qualified physicians, and part of what they assess is their English proficiency as well. So they are proficient in English, and of course, once they are at work, they consolidate or in the use of the language. But it is not that they come and learn English here. They can communicate right from the go with the rest of the operation.
Dr. Bolot.
Hello, Doctor. Dr. Michelle Bolot, and nice to see you again after many years. Wanted to congratulate you on the great work that you're doing, you've been doing for many years to address health disparities. Now, we have challenges we always have in closing the gap of health disparities, but can you speak to the issues of recruitment of qualified candidates, because that is a challenge. As some here know, being a primary care physician, as you're trying to recruit, is very different in Mexico than it is here in the United States, and it's some of us would like to see it a 4-year residency for primary care, particularly in family medicine I'm speaking of. But having said that, what's the recruitment like for you, and do you see any challenges coming your way?
Yeah, well, thank you so much for your question, and great to see you as well again. We are not involved in the recruitment. Our role has been just to be an independent evaluator. But I happen to know a little bit about, how these primary care physicians had been recruited out of once again, the Autonomous University of Mexico in Mexico City, and which is the largest university. Is huge, a huge university, and the dean of the medical school, who was recently replaced, Germán Guajardo, he has been a very strong support and supportive of this project, and he has a remarkable team of experts who have been very successful on not only recruiting but interviewing a lot of physicians. So they really have done, in my opinion, a wonderful job in. I have heard the word the cream of the crop, and of these physicians, and there is enough supply. But one of the things that they had been made very clear as well is that they would like to have this important workforce once they have the experience here in California, providing services primarily to Mexican populations during the rural areas, to go back and be placed in leadership positions as well. So it is a longer term kind of view about why they had been so committed to this program. But no, we haven't played a role in the specifics for physician recruitment. But one thing that I want to emphasize is, based on the recommendations on the qualitative interviews, that they would like to expand the type of primary care physicians, in addition to family doctors and internal medicine, pediatrics, etc., that they would like to have psychiatrists as well, because mental health has been one of the areas that is not being covered by the 27 physicians. And I can speak there because I had been doing population-based studies for over 3 decades, and in Mexican origin populations, boy, the treatment gaps, those who are in need of mental health services are way underutilizing services, especially those who were born in Mexico, and specifically the seasonally employed migrant workers, for example.
Thank you very much.
You're so welcome.
Other questions, comments from board members? All right, seeing none, Dr. Aguilar-Gaxiola, thank you for presenting your report to the board. We're going to open this up for public comments, first from those here in the room.
My pleasure.
All right, Sean, let's go to WebEx.
Can you hear me now?
Yes.
Yeah, a couple of very quick comments, since anything substantial I want to say will be interpreted as a legal issue. But you mentioned community clinics and specifically federally qualified health clinics a few times. No one should ever make the assumption that because something is a federally qualified health clinic or health center, that it's a good organization. That is essentially means they're totally unregulated. In my community in San Diego, Family Healthcare Centers of San Diego, I have determined it as a criminal enterprise. I did not come to that conclusion lightly. It took me a few years. I do have pretty convincing evidence to show people of that. Fraud is just everywhere there. Billing fraud, everywhere you look. It's really not even a healthcare center in any sense of the word. You might call it a training center for physicians, but it's not a health center. With mental health, which you mentioned a few times, it is incredibly important for everybody to know and understand there is no such thing as informed consent. That is a total myth. It just doesn't exist. Anything informed consent, they decide what is informed consent. Someone can claim they're your psychiatrist, for example, that you've never even met. And there's nothing you can do about it. It doesn't exist. So anyway, that's all I want to say about that. It sounds like your program is good, but do whatever you can to ensure people's rights, because it doesn't exist in the system. Thank you.
Thank you.
Okay, we'll bring it back to the room. Double check. All right. Dr. Aguilar-Gaxiola, thank you again for presenting to the board. Any more comments from board members before we move along? All right.
Okay, thank you for the opportunity.
Thank you. We're now going to move on to agenda item 7, executive management reports. And we are going to take questions and comments after the conclusion of all the reports. It's going to be perhaps a lengthy presentation, but hold your comments and questions until the end. Sean, are we going to start with you? Maybe? Or we can start with someone else.
Use my notes here to stay on track. Added a section about staffing updates for the IT unit here. We've had 2 more separations, unfortunately. One retirement and one moving on to DCA to help with their data services over there. And so we've got a lot of recruitments going on. 4 positions have been posted and are currently being scored. We're going to start doing some interviews the first week of December on those. Just to mention also, a website developer position that was vacant was swept in the vacancy sweep, the reduction, and so that was one position we had to give up there. We'll be absorbing those and the rest of the those duties in the rest of the programming team. Unfortunate, but we should be able to make do. Throughout the board and the headquarters office and the 12 HQIU offices throughout the state, we're doing a bunch of hardware refreshes that have we've had the hardware since earlier in this year. We're finally getting out and traveling and starting to do those updates. Started with the HQIU office in Tustin, who relocated to Santa Ana. Got them up online earlier in the month and running on the new hardware, so we've got 11 more trips to make. most of them down here down south, and then a bunch of work to do at the headquarter office in Sacramento. In February of 2025, the Rancho Cucamonga HQAU office will be moving and merging in with the San Bernardino office. HQAU is doing a little shuffling around, I believe, for budget concerns and things. But so we'll be assisting them with that movement and helping them set up some hoteling cubes and things like that. And then they're also losing their lease in their Valencia office, so we will be helping them move out at the end of March. New location to be determined. We'll just be helping them work remotely until a new area is found. Sorry, my nose is not cooperating this morning. The iOS application update, we're still testing on that. Was really hoping to have an exact date for you guys here yet today, but we want to make sure it's all tested and thoroughly working. Still hope to have it launched here by the end of 2024, but that'll be a big one. That leads into the complaint tracking system, because the same programmer resource working on that will be working on the complaint tracking system. I've been wearing a lot of hats recently, so I don't have any formal burn down charts or anything to show you guys. We're still planning a 12-month development cycle on the complaint tracking system, most of that being really testing. But I hope by our next board meeting I'll be able to show you all those, and when we have dedicated program resources, have more accurate estimates for you on that stuff. For the HCI survey, still have this included in here basically just to show you when we reach the max value of people that we can have reporting in our physician surgeon population, at least, even though all licensees do this survey now. The physician surgeon one's the one we track the most, because we want to make sure, again, we get to about that theoretical limit of around 85%. So we're just above 80% now. It's tapered down last quarter. I don't have a chart in there for you, but last quarter we reported 5% additional had added, and this quarter it was only 1.5, so we're definitely getting to that plateau. The wallet licenses project, again, that's just for informational only update how many of those were issued there. We still would like to expand that project to have them generate a sign for their waiting room that has a QR code that you can scan and go right to their profile. So I keep that project on here because we have kind of a follow-up on there, but again, just looking for programmer resources to kind of work on that. Excited to launch some new docs enhancements that they're actively testing right now. We hope that'll be in early December. That will allow the licensees that have to prove their postgraduate training information for their initial license renewal. That'll allow the schools and the programs to update that stuff. The testing's going on that. Development's all done. Initial testing looks good. So we think the first half of December 2024 for that. The voluntary physician registry testing is completed on that. If I weren't here this week, we'd be launching that this week. So I hope to be doing that before Thanksgiving next week. Getting that all blind, it's just modernizing that basically and taking the licensees to an interface that they're used to called the Ideal interface, where they log in with their personal identifying information the same way you do with your surveys and things like that. So just bringing that up to date to modern standards and security. The Breeze online complaint form redesign project, the enhanced code from the Breeze vendor that was supposed to be available in October of 2024 got pushed out to January 2025. I believe it had to do with all the legislative stuff they had to implement department-wide. So that's going to push our time frame out for customizing it and getting our refined complaint form up online. So we're revise that to mid-2025. Again, when we see the code and the code is available, we can configure it. Hopefully it's no later than that. And then new projects kind of came up out of the attempt to reduce budget stuff further, and I don't want to step on Doug's toes because I know licensing is going to talk about it a lot, but we're going to be switching all of the renewal forms to electronic only. So I think Doug's got a lot of detail on it, but over the course of the next 2 years, basically we'll be phasing out paper renewal forms, and so I'll kick it over to Doug and let him expand on that.
All right, thank you.
Thanks, Sean. Hi, Doug.
Thank you. There we go. Licensing program update for quarter one. So in 24-25, we received 2,376 initial license applications. It breaks down to 924 physician and surgeon's license, 532 transition, and 920 PTLs. We also issued a total of 4,138 licenses, which breaks down to 2,174 physician and surgeon and 1,964 PTLs. We updated a few forms. We updated the completion of postgraduate training form by removing the notary and seal sections and updating language stating that the form can only be submitted through docs. Additionally, it clarifies the form is exclusively for applicants. We also updated our initial license renewal postgraduate training form to reflect that it can be signed up to 30 days prior to completion of training. Additionally, it clarifies that the form is exclusively for licensees. And we also updated the postgraduate training licensing enrollment form to indicate that PTLs will be valid for 36 months. We also added fellowship as a program type. In addition, the question was removed, the research question was removed since the board no longer needs this information. These updates will ease the completion of forms and reduce form deficiencies. Moving on to our website updates. The board's website was updated to allow verification of whether a medical school or postgraduate training program is registered in docs. Applicants can now verify their medical school or training program's docs registration on the board's website. This is ideally avoiding unnecessary delays in submitting documents to the board. And kind of going where Sean was at, efficiency update. Continuing our pursuit to be paperless. Starting with licensees that expire June 30th, 2025, we will no longer mail paper license renewal notices to PNS licensees. Those with a PNS license that expire June 30th, 2025 or later will be required to renew online through Breeze. The board will continue to email renewal reminders to the licensee's address on file. So moving on to a Breeze update. Applicants previously licensed in California can now apply online through Breeze. Previously, these licensees were required to mail in paper applications. Webmaster update. The licensing program responded to 2,574 emails. In Q1, the most responded topics during this quarter were application status checks, first-time license renewals, and CME questions. For outreach, in Q1, licensing staff and management conducted 11 outreach events on licensure processes and requirements, which included 8 live webinars and 3 in-person presentations. And the CIU call center. Q1, CIU received 17,087 calls with an average wait time of 5 minutes. 3 of the topics most responded to were complaint questions, complaint forms mailed, and Breeze tech support questions. And that's it for Q1 from licensing.
Thank you. I think we're going to move on to the enforcement summary. Ms. Jones?
Good morning, or good afternoon, board members. My name is Jenna Jones, and I am here to provide a brief overview of what's been going on in enforcement. We have been very busy trying to get the new complaint liaison unit established. We had well over 150 applications for the unit. And manager, and so we are hoping to have those people on board in December. We are also working on a very robust training program for those new team members because they need to understand the entire enforcement process as well as how to help people file a complaint. So it's going to be a very, as I said, robust, very extensive training program that we're going to put them through with each department in the complaint process, as well as introducing the other areas of the program to them. So they'll understand overall how a lot of our processes or who to contact in case they have a question. We're hoping that we can alleviate or assist the call-in center because they do receive so many complaint calls. We're also hoping we can assist CCU with their workload and by taking those general questions off their daily desk. So we have had a great response with the applicants and we're looking forward to getting that underway. So we're shooting for January 1st and so we can meet the requirements of doing the interviews, et cetera. So we're looking forward to that program. We've also been very busy with the expert unit. The expert unit is out doing recruitments. They're trying to focus on certain specialties right now, and they're doing direct emails to those individuals that have those qualifications. They've had a good response with the direct emails. They also provided a representative to attend a recent CMA meeting, and they had a lot of interest and people that were interested in the program. So we encourage you all as board members to continue to encourage people to volunteer for the program. We know the pay is not the highest, but it is a very worthy service to the community and the public. So we just ask for that assistance. We've also been very busy with working with HQIU and the Attorney General's Office on a collaborative process. We've been trying to establish guidelines of which cases would be in that process right off the bat, as soon as they are assigned to HQIU. And we've had a lot of good feedback, and we've made a lot of progress, and we hope to have that wrapped up, or at least something to present to you in the next couple of months. So that's been a very worthwhile process, and we are looking forward to getting that underway as well. So I'm happy to answer any other questions. Our stats are in the work report, or in the board report. So if you have any other questions.
Thank you. We'll move on to the administrative summary, and then we'll come back around for any questions everyone has.
Thank you,
Mr.
Madam.
Varese.
Thank you, Madam President, and the members of the board. So the administrative updates, the staff actually meet on a regular basis with the board leadership and the board members, AG's office, DCA, HQIU, and other local, state, and national organizations on various matters. Moving on to staffing updates. Board's current vacancy rate, I would say, is at a manageable level. Once we fill the 9 new CLU positions that you heard Jenna spoke about a few minutes ago, the vacancy rate will drop downward dramatically. And also wanted to report that the recruitment of new staff members, training, and retention activities are the top priorities for our HR department, and their efforts are very well received, and the morale at the agency, I would say, is at the highest of its in the past few years. The more importantly, I wanted to focus on our budget update. It's in your notebook. The details in the notebook, I'm not going to read all of that, but just to summarize, the board closed its books for FY 23-24 with better than expected results. We had a year-end months in reserve of 19 months of funds. Total expenditure was under the budgeted amount, and the collected amount, we collected more than estimated revenue. This enabled us to repay the loans that were taken earlier at an earlier date, and also we saved on interest on those loans. The fund condition report on page BRD 7D9 will show an additional loan we anticipate this fiscal year if needed, and to help with their financial condition, as it is still in the path to the solvency, while the full effect of the fee increase is yet to take place. The total dollar amount of the loan is, the projected loan is just an estimate at this early stage of the fiscal year. And moving on to the next paragraph in that budget summary, I wanted to report that the Budget Act, the 2024 Budget Act required state agencies, departments to reduce our budget expenditure by 7.95%. So we also had to come up with that savings, and then the expenditure reduction will be a permanent budget reduction in fiscal year 25-26. In addition to the dollar amount expenditure reduction of 7.95%, we were also asked to come up with a statewide, participate in a statewide vacancy reduction initiative, and our share of 5 vacant positions that were identified may not be filled this fiscal year and will be permanently eliminated effective July 1 of 2025. And one of the position is the one that Sean mentioned. Now, how that will affect our operation is yet to be seen, but you can only anticipate that some of our projects will be delayed because we have to rely on the current resources in getting our work done. Moving on to the last section in my report is a media relations and external communication update. On November 15th, I presented to the California Association of Medical Staff Services at their annual virtual fall conference. And in October 25-27, the board staff were present, 25, 26, and 27, all 3 days. The board staff and myself were presented at the CMA's annual House of Delegates meeting, and that we had a booth there, and we were able to meet with a lot of physicians, and we distributed copies of our opioid guidelines to a lot of physicians that come by the booth, and also it helped us to meet physicians and explain our medical consultant and medical expert program, and we had a lot of interest in that regard, and then many actually did sign up, filled out the contract or committed themselves to go online and fill out the contract. So hopefully we'll see some results in that. So, and also Dr. Thorpe was also a great help at that conference. And then also on October 24, 2024, the board held an interested parties meeting on draft legislation that would establish the Physician Health and Wellness Program, and the rest of the activities. And we continue to help the CDPH and the others in disseminating information on many health-related public announcements. So we continue to do that, and we also publish our annual report and the Q2 newsletter since our last board meeting. So that concludes my prepared remarks, Madam President, and my team and myself are available for any questions that you may have.
Thank you, Mr. Varghese, and to all the staff members for your presentations. Are there any comments or questions from board members? Dr. Yip.
Hi, I may have missed it. What is the status of the online self-study module for training expert now? I understand we have a vendor that is going to provide an online self-study training for the expert.
It's not a vendor, Doctor. I'll answer that. And yeah.
Dr. Yip, it's actually an internal program. The system is, we purchased from a vendor, but we will actually develop and initiate it, and the expert unit is very busy in creating those modules. And I believe we're gonna have a test group, hopefully later in December, established to start processing those, testing and beta testing, or whatever you want to call it, but we hope to have that rolled out next spring for everyone. And it will be a self-study online training program for the experts versus the one-day seminars that we currently hold. So they've made great progress in the last month or so that's why we're hoping that'll be the end of December.
I think one of the issues, not just the reimbursement. I think the reluctance of expert to go for to testify. So I think the program or maybe the DAG office can help train that to have the expert more confident or more prepared to attend those hearings.
Yes, we will still involve them in the process.
Other questions, comments from board members about the executive reports? Dr. Tsai.
I just, a couple of things for the iOS update. I'm sure it's now 18 instead of just 17 because everything's now iOS 18.
We target them by the actual phone and when they're going to expire it. So yeah, it's actually 17 still, but yeah.
Okay. And the other thing is I know everything's going electronic. For all the residents who are finishing, they may filled out their training program emails. And so I think it behooves us to advertise to say, hey, keep your email addresses current or else they won't get any notice.
I'll jump in on that. So yeah, part of that phase out the next 2 years, instead of getting a renewal notice like they're used to receive, like you're used to receiving, right? You know, that 8-page packet, you're going to get a 1-page letter, and it's going to have details there about. Be sure, it's law to keep it up to date with us, and you won't receive further notifications about this in the future. So yeah, and then we'll switch from sending you one email address or one email at 180 days prior to your renewal to 180 days, 150 days, 120 days. We'll bombard you with email. But yeah, we do hope that people, put a little plug in here that, any licensees that hear this, please do remember to keep your email address up to date with us, because that'll be the main way of getting a hold of you in the future. So.
Thanks, Dr. Tsai. Any other comments, questions down here? All right, we'll go to Mr. Watkins and then Dr. Ayala Rodriguez.
Well, I just want to say thank you to everyone. My question is to Ms. Jones. I like the fact that we are sensitive to what was in the, monitor's report about collaboration between the AG's office and HQIU. But I had a question. Who investigates substance use cases? Is it HQI? Is it within the board? I was just curious. It just popped in my head.
The substance abuse cases?
Yeah.
Most of those go to HQIU.
Most of it goes to HQIU.
Yes.
Okay.
I would
thank
say
you.
all.
All of it goes to HQIU.
There may be just a few that are handled, the DUIs may be handled by CIO, which is our internal
Right.
non-sworn group. But if they're impairment issues, they would be referred out to HQIU. But I apologize, I misspoke. The DUIs initially start with CIO,
Okay.
the internal unit.
Okay, thank you.
Dr. Ayala Rodriguez.
Thank you so much. And thank you so much for the report. I really appreciate all the updates. I think that that's going to streamline so many processes. My comment is more towards the HCI survey update, anticipated year of retirement for physicians along with the budget. My recommendation or comment would be just to be very, very proactive about that, because we know that maybe 40% of the physicians might retire by 2033. So have really connections with budgeting, because if we think that 40% of our membership could lose and that could affect budget and things like that, I think that it's very important for the board to really have those projections of how membership could change year over year to make sure that we plan accordingly.
Any other additional comments, questions from board members? Sean, do you want to add a
just a real
comment or question?
The HCI survey thing. While we are able, if you guys are interested, we can help pull stats and do kind of that stuff too. But in our ongoing meetings with HCI about the survey, and in fact, there will be a change. I'll just take a little detour here real quick. January 1st, I'm sure Aaron will be talking about this. There's a new bill that makes the NPI number required in there as well too, if they have one. So we'll be editing the survey to do that. I forgot to mention that earlier, but if you are interested in those stats, while we can pull them as well too, HCI is building this dashboard that can be used to look at that data in aggregate and stuff too. And they've talked about in meetings about eventually showing those dashboards to the executives of the different boards that are working on that survey with them. And then, I think eventually we could also, if you're interested, agenda item for getting someone from HCI to come in and give you a whole presentation on a lot of that stuff. So I'll just throw that out there.
Thanks, Sean. Dr. Thorpe?
Well, thank you all very much for the hard work that you're doing. And I want to commend also for all the hard work on, it's really amazing to me that we have a budget surplus, a little bit of a budget surplus. I realize it's because of loans, and so for those of you who weren't on the board, the board has had significant budgetary challenges for a number of years, and fortunately because of Sunset Review, we've had a dues increase. But Reg, I noticed that there's another loan that might be needed for this fiscal year, $27 million. Could you speak to that and what the anticipated repayment and how that will affect our bottom line?
That's correct. So on in your notebook, BRD 7D9, that's a page where you will see the fund condition report, and you will notice that the column number 2, current fiscal year 24-25, is where that $27 million plugged in. And again, like I mentioned in my narrative, that is just an estimated amount at this point. And like in the previous fiscal years, we played with those numbers where we anticipated taking, like earlier in the fiscal year, taking $14 million or $12 million or $10 million. But by the time the fiscal year rolled up towards the last quarter of the fiscal year, we looked at the financial condition and we really didn't have to take all that loan at that, towards the end of the fiscal year. So we are in the same boat right now with this $27 million plug in there. There's also a difference, and the difference is the previous loans, we had to repay that in 2 years, right? But this is a special loan that, as you will notice on that fund condition report, we have a number of years to pay that back, not just 2 years. So that is a special provision in the Budget Act that allowed us to do that. Again, like I said, we may or may not need that $27 million. Whatever it is, we'll know. Again, that's for allowing us to keep us solvent until we get the full fee increase impact, and that tells us. And at the same time, as I mentioned in my previous reports, we are not just relying on just these loans or fees or revenues, but we're also doing a lot of other activities like cost reduction measures, process improvements, and at the same time focusing more on our cost recovery. That's another that helps us with our cash balance. And also we have a process in place to we don't have a process in place to collect the debts that owe to us. Like, so if we have a cite and fine, right, and if they don't pay in 3 years, the current process is to refer that to the Franchise Tax Board. Well, that's a black hole. We may or may not see anything, once you refer there. So we are embarking on some projects and working with DCA to see if we can get a contract in place for collection activities to collect the money that owed to us. So these are all activities taking place to improve our fund condition and cash flow. So hopefully, with all that measure, this loan environment that we're working on will be gone in the future, and so we can self-sustain our board going forward. Thank you for that question.
Additional comments, questions? All right, we will open it up for public comment. Any public comment from those in the room? All right, welcome back to the quarterly meeting of the Medical Board of California. It's 1:18 p.m. We are going to move right into agenda item 8, which is updates from external stakeholders. And like the previous agenda item, we'll take all comments and questions after we hear from DCA, HQIU, and the AG's office as well. So first up, Melissa Gear from the Department of Consumer Affairs. Welcome.
Thank you. Hello and good afternoon, President Lawson, Vice President Dr. Hielzer, Executive Director Varghese, and members of the board. I'm Melissa Gear, Deputy Director for Board and Bureau Relations, and I appreciate the opportunity to share the Department of Consumer Affairs update this afternoon. Before my update, I want to welcome our newest board member, Jody Remke, and Wendy Mitchell to their first meeting. I appreciate your commitment to serve and protect California's consumers and look forward to working with you. I also just want to say thank you to all of our new board members who have been going through Senate confirmation process. Thanks for indulging me and all of the many emails you've received. We're almost to the end, so thank you, and I appreciate your patience. So with that, I will now jump right into my update, which is included in your packets. So please feel free to follow along as I highlight a few updates and reminders, but I won't go through all of them. So first, I'll start with the DEI update. DCA's Diversity, Equity, and Inclusion Steering Committee met last month, and we are excited to announce its newly elected leadership. Reggie Varghese, the Medical Board of California's Executive Director, will serve as chair, and Marlon McManus, the Board of Behavioral Sciences Assistant Executive Officer, will serve as vice chair. With Reggie and Marlon's years of experience and sincere commitment, we greatly look forward to accomplishing many DEI initiatives under their leadership. Next, we have a new unconscious bias training for board members. I am also excited to share that DCA is updating its current Unveiling Unconscious Bias training to focus on board members, your critical roles, and how unconscious bias can affect your decision-making authority. The training will be self-paced and available in DCA's Online Learning Management System, or LMS, and we anticipate launching this new training in early 2025, and board members will be required to take it annually. Next is an update on our Promise campaign launch, State Employees Giving at Work campaign. We are officially in the season of giving, and DCA is honored to join in the annual charitable campaign launching this month, the state's Our Promise campaign. Every year through the Our Promise California State Employees Charitable Campaign, state employees, including board members, have the opportunity to support the nonprofit causes they are passionate about through payroll giving or one-time donations. These contributions have a positive impact on our communities and are another way for DCA to show it cares for California. This year's campaign is led by Monica Vargas, Deputy Director of Communications, and Karen Navarro, Assistant Deputy Director of Communication. DCA's campaign officially launched this week. I saw the email come out this morning, and will run through December 31st. In the meantime, please contact Board and Bureau Relations with any questions or if you would like any information on how you can give. And lastly, I'd just like to take this opportunity to say thank you for allowing me to join you today, and if you have any questions, please feel free to ask. Thank you.
Thank you so much for your report. I think we are now going to hear from Ms. Nichols and Ms. Whitley from HQIU.
Yes, good afternoon. I am Chief Kathleen Nichols with the Division of Investigation, and also with me is Stephanie Whitley, Deputy Chief for the Division of Investigation's Health Quality Investigation Unit. It is our pleasure to provide the board an update on the Health Quality Investigation Unit, also known as HQIU. HQIU currently has 18 investigator vacancies, equaling a 22% vacancy rate. 2 new investigators have started in November, with 1 additional candidate cleared and pending a start date. There are 10 candidates in background, 4 of which are in the final psychological and medical portion of the process. In the meantime, we continue to screen new applications for each HQIU office on a repetitive 30-day cycle so we can quickly fill the remaining vacancies. The Division of Investigation has started a new wellness program, which is intended to be a holistic approach to staff's well-being, encompassing aspects such as physical fitness, mental health, and overall wellness. We are extremely proud and excited to be one of the first state agencies selected to be part of the program, which is sponsored by California's Commission on Peace Officer Standards and Training, POST, in partnership with UC San Diego. The primary goals of the wellness program are to increase staff retention and support a healthy quality of life for division members. And I'll turn it over to Deputy Chief Whitley for the conclusion of our update.
Good afternoon. One challenge we are facing with recruitment is the elimination of the state's hire above minimum process, also known as HAM. As of October 1st, all state departments lost individual delegation to issue HAMs. Historically, the division has utilized the HAM process to hire individuals who have vast knowledge and experience from outside agencies and were able to start them at a higher salary than the bottom of the pay scale. The division applied to be considered for CalHR's new HAM Plus process, which is an automatic higher starting salary base on classification. However, the investigator classification was not included. We have elevated our concerns regarding the significant impact this will have on DOI's hiring process. HQIU has made progress on our pending workload in cases over a year old, as demonstrated in our updated graphs and board agenda material item 8B. In addition to sharing an automated monthly report with case statuses updates, HQIU leadership continues to hold weekly meetings with board staff to discuss cases, answer questions, and resolve issues efficiently. We look forward to our continued meetings with board staff. This concludes our report, and we'd be happy to answer any questions.
Thank you, Ms. Nichols and Ms. Whitley. We're now going to hear from the Attorney General's office. Ms. Castro,
Thank you very
welcome.
much, Ms. Lawson. Today I have with me 2 members of our team, so I'll introduce them shortly. Wanted to take a minute to congratulate and welcome all the new board members. We look very much to serving you. Look forward to that. I am pleased to introduce to you Ashley Harp and Maria Salerio, Staff Services Managers 3 and 2 respectively, from the Division of Operations, Attorney General's Office, Department of Justice. Maria Salerio and Ashley Harp last appeared before the medical board in August 2021 and August 2023 to respond to the medical board's questions regarding the Legal Services Revolving Fund, also known as the LSRF, and the Attorney General billing rates. At your last meeting in August 2024, you received a copy of Chief Deputy Attorney General's Venus Johnson's letter to the Department of Justice clients concerning the July 1st, 2024 Attorney General billing rate increases. As you may recall, the prior Attorney General billing rate increase was implemented in July of 2019, 5 fiscal years ago. We note that the 2019 billing rate increase was not applied to the medical board until July 2020. In the past, you have received frequently asked questions related to topics within the Attorney General's billings rates. We have provided 2 handouts for you today for your reference. They are in your board materials at pages 8C1 through 8C7, and it may also be helpful for you to reference Agenda Item 7D13 and Agenda Item 7D14 from your materials as well. Thanks again for inviting us here today to assist you. It's a privilege and honor to be able to participate in the protection of the health and safety of California consumers on your behalf. I now turn it over to Maria Salerio to address some prepared questions. Thank you.
Good afternoon, everyone. I'm Maria Salerio with the Department of Justice's Budget Office. We were asked to explain the cost recovery of the Attorney General's legal staff time. The Attorney General's office is authorized to recover its costs from legal representation of state agencies under the authority of the Legal Services Revolving Fund, also known as LSRF, under the purview of the Government Code Section 11044. This system allows the Attorney General's office to recover its costs for legal work performed on behalf of state agencies. For accounting purposes, each state agency is assigned a specific client code, and all matters open for the medical board are assigned to the medical board's client code. At least 4 sections in the Civil Law Division provides legal services to the medical board, which are billed and recovered on a monthly basis. These sections are the Health Quality Enforcement section, also known as HQE, the Government Law section, the Health Education and Welfare section, and the Torts and Condemnation section. The majority of legal services provided by Health Quality Enforcement section relate to the administrative matters associated writs and appeals, third-party subpoenas, and internal client services such as counsel and advice. The legal work performed by the Government Law section and the Health Education and Welfare section centers on defense work on behalf of the medical board, its staff and officers in constitutional litigation brought against the state. The legal work of the Tort and Condemnation section is centered on defending the medical board, its staff and officers in lawsuits brought by plaintiffs seeking damages. The Department of Justice uses a case management and timekeeping system called ProLaw. When work is received from a client, a matter is opened in ProLaw and assigned to the medical board's billing code. Transactions, which are time entries by the legal professionals, are associated to the matter throughout the life of the case as work is completed. The transactions include the time it took to complete the tasks, a task code that summarizes the effort, and a narrative that provides the detail of the work completed. Every month, the transactions are processed and an invoice is generated and sent to the clients by DOJ's accounting office. Additionally, a detailed billing report is sent to the clients that include the transaction details for all of the cases billed during the month. As reflected in the frequently asked questions document and in the Chief Deputy Attorney General Venus Johnson's letter as of July 1, 2024, the billing rates were updated as follows. The attorney rates is updated to $228, paralegals at $213, and analysts at $202. Using the attorney billing rate as an example, the billing rate is an increase of $8 from the old attorney billing rate of $220, which is a 4% increase and the first increase in 5 fiscal years. We were also asked to explain why billings fluctuate month to month and why we go over or under the allocated legal services revolving fund. This fiscal year 24-25, we project that we will not exhaust the allotted Legal Services Revolving Fund budget of $16,941,000 based on a monthly average billings. Assuming that monthly average billings continue as of September 30th, 2024, we project that we will not utilize $198,532. We note that the MBC is the sole agency responsible for determining how to investigate, categorize, and prioritize a case, and when and how to refer it to the DOJ for handling. MBC also determines the volume of work that the AGO that comes to the AGO and what programs are supported. Billings draw from the LSRF as you assign to us when you decide on your operating budget each fiscal year. We were also asked to explain our billings to General Client Services. General Client Services billings include all non-case specific legal work that is related to the MBC's legal work but not billed to a case. This includes all general monthly reports provided to you by members of the Health Quality Enforcement Section for unpled cases, cases needing action, and other Attorney General privileged information. This also includes, for example, quarterly case reviews, internal template creation, preparing for non-adoption hearings, preparing for closed session meetings, internal legal training relating to policy and law changes enacted by the MBC, milestone entry analysis for the data tracking needed for the annual report required by the Business and Professions Section Code 312.2, and other tasks that cannot be assigned to a case. General Client Services billing also includes investigator and medical consultant training provided by assigned legal professionals to the MBC's Complaint Investigation Office and the DCA's Health Quality Investigation Unit. These trainings are developed with a goal to enhance efficient management of your cases, such as calculation of statute of limitations, subpoena enforcement, and subject interview attendance. Billings are consistent with our mandates under the Government Code Section 12529 et sequentia, which require that the Health Quality Enforcement Section, among other responsibilities, to provide initial and in-service training programs for staff of the boards, including investigations. This concludes the initial overview. I now welcome back Sag Castro for the rest of the presentation. Thank you.
Thank you so much, Maria and Ashley, to both of you for your time on this and for this very valuable information. Finally, we were also asked to advise the medical board today regarding the number of hours and dollar amounts billed to non-administrative litigation matters in the current fiscal year and the past two fiscal years before that. So generally speaking, for fiscal year 2022, 2023, 23 and 24, and to the present through September 30th, 2024, we have handled at least 57 non-administrative litigation matters. And as noted, this can include the work of the Health Quality Enforcement Section and other sections within the Attorney General's office. In total, we have billed approximately 7,700 hours or $1,768,804 to these types of matters. And the breakdown by fiscal year are as follows in hours and dollars. In fiscal year 2022-2023, we handled 34 matters of this type for a total of $820,000 and $820,353 and 3,736 hours of legal work. Likewise, in fiscal year 23-24, we spent 3,212 hours on 44 matters for a total of $758,611. And finally, through September 30th, 2024, in fiscal year 24-25, we have spent thus far 752 hours on 26 matters for a total of $189,840 of legal fees. So like I said, this figure includes billing by the Health Quality Enforcement Section and other sections to non-administrative litigation defense, as well as lawsuits seeking damages where we defend board members, executive staff, and investigators. So this concludes the Health Quality Enforcement Section's formal presentation. Again, special thanks to Ashley Harp and Maria Salerio for being present here today. And as always, it's a pleasure to be here and to answer any questions that you may have. Thank you. And that concludes our remarks.
Ms. Castro and team, thank you for those updates. I'll bring it back to the board to find out if there's any questions or comments from any of the members for any of the three external stakeholders. No questions or comments today. Okay. Let's go to public comment in the room. Any questions, comments from those present in the hearing room? Sean, how about on WebEx?
Yeah, hi. I'll be careful not to allude to any current issues, but first of all, to anybody who has been through this process, as far as we're concerned, the California Attorney General and the Medical Board of California, they're one and the same. It's like two departments of the same company. Also, as I understand it, in your cases, in most cases, the Attorney General of California represents all the people. But in these specific cases, you represent the chief executive or the CEO, whether it is of the medical board itself. I have often said, or I have observed, that if you have a complaint about a mental health issue, you lose every single right you have as an American. The one exception, I believe, is the Freedom of Information Act in California. It's called the Public Records Act request or whatever. You also deny that. Could you consider sending out a letter when those rights are reinstored? As you should know, the medical board has exempted itself from all California Public Records Act requests. So it's essentially, for any complaint, especially against a mental health professional, you essentially have a government that operates in secret. So that's my comment, and if you can respond, I would appreciate it.
Okay, we'll bring it back to the board. Oh, Mr. Watkins.
Yes, my question is to HQIU, Ms. Nichols. I was curious, this 538 or 528 cases that is over 365 days, do you have a breakdown on what type of cases they are? If it's gross negligence, sexual misconduct, do you perhaps have that, or, I'm just curious, as usual.
We could get back to you with that data to see if it could be fully broken down through Breeze. There are a variety of different case types.
Any other questions, comments? Dr. Mahmood?
My question is particularly to the Attorney General's office, especially about this attorney fee. I see the gap between paralegal and attorney fee is so close that we are almost paying the same amount to attorneys as well as paralegal. So is there any advantage to use paralegal to get a quality service? We're paying the same fee to get the service, because our major handicap is that we lose the cases because our attorneys are probably not up to the par or whatever. So is there an explanation for this thing? This gap is so close and it's gone basically almost equal over last many years.
I don't know the answer to that. Ashley Harp or Maria Solerio may know, but I do want to say that our paralegals are very, very experienced, and they actually perform paraprofessional tasks that are 100% needed in every single one of your cases. So while you note that the compaction is tight between analysts, paralegals, and attorneys, if I could point out the hourly fees for other folks involved in your work, the administrative law judges, they raise their fees every year. And so in calendar year 23-24, their hourly rate to hear your cases, for example, was $373. And currently it's $395. Your experts bill on an average of $150 to $200 an hour. And investigators their rates fluctuate every year for DCA. And the last time I checked, I think on an hourly basis, they bill 173 hours. So that is sort of where you're at right now with your retention of professional services to handle your work. But obviously, in order to practice law in California, you need a lawyer. And so our paralegals do not practice law, but they do work at the direction of our lawyers, and excellently, I should add. Maria and Ashley, do you have anything to add on the compaction rate?
Thank you, Gloria. I don't really have anything to add. What you said, I agree absolutely with what you had explained. There isn't an advantage. I think that the functions of each of the professional types are very set to the activities that they perform. And so, yeah, thank you.
And Dr. Mahmood, so for instance, for hearings, all those hearings are performed by video conference or in person, depending on what the administrative law judge requests. All of our paralegals are second chairs to every single case. Why? Well, everything is digital. Oftentimes opposing counsel and respondents do not come in super tech savvy with how to manage projection of documents during hearings. So we couldn't do anything without our paralegals. Our paralegals also work very closely with Kathleen Nichols and Stephanie Whitley's staff. They're the ones that compile loads of evidence that could be tens of thousands of pages long, and they produce this material to us in zip files. Each paralegal has to unzip those zip files full of evidence and arrange every single piece of evidence for our lawyers before we can even review the case. And they work very closely hand in glove with HKU to make sure that we have all the materials from the reports of investigation and that they're arranged in a proper format. So I think they're worth every penny, personally, even if it's very closely compacted to my rate. Also, that the rate of the lawyers doesn't matter between what I bill and what the most junior lawyer bills. We have a couple of those junior deputies that have been in practice maybe 4 or 5 years. We all bill the same exact rate. So it's not like a typical law firm where if the partner was billing, they'd be billing at a much higher rate than the most junior person. So it's sort of just pretty fair. And I think it also helps us operate as a team because we're all like just as valuable as each other. And I have no issues with that.
My only assumption is I think this is completely in contrast to what the real world is doing. Either we are doing something very unique and very special, or other world is doing something strange. The rates for paralegals in medical, the DCA is way high, and rates for the attorneys way too low. And I can't really find the real explanation with all this description. Why is that why we are paying almost double the amount to the paralegals and not the half the amount to the attorneys, and our results are not, to be very honest, I want to be very blunt and straightforward. In our hearings, our win rate is very low. And we have talked this over the years that quality or amount of money we're paying to the attorneys, the people who are taking the interest, is not because people from outside are being paid very high. So that is why I just brought this up, that there is something, it has been done, but somebody need to look into this thing, where is something lacking, and where we can make sure that our expert attorneys or our legal people are appropriately paid so that we can have a higher win rate and we can protect California's better way. Thank you.
Other comments or questions? All right, Ms. Castro and team, Ms. Nichols, Ms. Whitley, and also Ms. Gear, thank you all for your presentations. We're going to move on to agenda item 9, discussion and possible action on legislation implementation plans. Mr. Bone.
Thank you, Madam President. Good afternoon, members. We're on agenda item 9, so first thing I would do is direct your attention to the blue and green color-coded tracker chart. The legislature completed their main work for this 2-year session in this past August, and the governor finished signing and vetoing bills on September 30th. And this time of year is when we take a look at the bills that were signed into law by the governor that the board took a position upon and how we're going to implement them. The legislature is currently in recess, and they will be returning in early December to swear in newly elected members, and then they will return in early January to resume their work in earnest. At this time, I will just briefly go through each bill on the agenda, and then we'll take questions and comments at the end. And then again, referring to that color-coded chart, the green items we'll be discussing. The blue items were bills that the governor vetoed, and so therefore nothing to implement there. As I go through each of these, you will hear me say for each one that they will get a mention in our upcoming newsletter that is going to be issued around the end of this year. And what I mean by that is in that final issue, we do at least a brief description and a link to language and other analyses, and that folks can get information about them. It's bills that we've been talking about as well as other bills that I've been tracking on behalf of the board. And we commonly refer to that as the new law roundup. So you'll see that for each and every one of these bills. First bill up is AB 796, which would establish title protection for athletic trainers. Members may recall that originally it was going to be licensure for athletic trainers to be handled here by the board, but that was not the case, fortunately. And so there's no implementation task for us. We're going to put this in the new law roundup. It just says what you need to do in order to call yourself an athletic trainer here in California. The next is AB 1991, which requires licensees of the various healing arts boards to provide their National Provider Identifier, or NPI, if they have one, when they renew or register, when they renew their license or registration online. You heard Sean mention this one earlier in his presentation. The staff are already in the process of updating the survey. This will be all included in the new law roundup, and then we want to write an article in next year's newsletter to encourage licensees to respond to the survey in full, because licensees can decline those questions. Next is Assembly Bill 2164 that prohibits the board from requiring an applicant for a physician's and surgeon's license or postgraduate training license to self-disclose conditions or disorders that do not impair their ability to practice safely or for which they are receiving appropriate treatment. In the board's August meeting, the board approved updated language for these license applications to comply with this bill. Applications are being updated and will be online in January. And we will be, again, including this in the new law roundup, and we want to do another newsletter article to highlight this change next year. Next is AB 2860, which extends and updates the Licensed Physicians from Mexico pilot program, which is the same one that you heard Dr. Aguilar Gaxiola talking about this morning. To implement this new law, the board staff are updating application forms, related application review procedures, and will be determining what staffing and training needs will be required in order to process applications in a timely manner, which under this new law will be starting to receive those in October of next year. The board's website content will be updated, and changes to this successful program will be featured in a newsletter article next year and also be included in the new law roundup. Next is a closely related bill, AB 2864, which authorizes extending the expiration date for the existing participants in the LPMPP for a 3-year period. Licensing staff are well underway processing and issuing extension requests, and we'll include a write-up about this in the article next year along with AB 2860. Moving on to AB 3030, this requires physicians and health facilities to disclose certain uses of generative artificial intelligence to their patients. This new law could have a broad impact on the board's licensees, so staff plan to increase awareness through a standalone email to licensees next month, putting content on our website and then do a feature article in this next issue of the newsletter, along with including it in the new law roundup. And there's going to be a new code in the Breeze system that we'll be able to use to track future complaints that we may receive. Next is Senate Bill 607, which updates an existing law to require prescribers to discuss the risks and dangers associated with opioids and potential opioid misuse. For this one, we'll be adding new content to our website, a newsletter article on this specific topic, and also include that in the new law roundup. SB 639 updates continuing medical education, or CME, requirements to encourage certain physicians to take coursework on the special care needs of patients with dementia. To implement this one, staff will make any necessary updates to its CME audit procedures and contact letters, adjust our relevant website content, and include this in the new law roundup. That's followed by SB 1451, which is one that we haven't discussed yet, which was amended late August in order to include language requested by the board to provide an alternative renewal pathway for those with a physician's and surgeon's license who can't meet the requirement to renew their license because they have not yet completed 36 months of postgraduate training. We're happy to have been able to accomplish this so that those who are still establishing their medical career have a bit more flexibility to finish their training and hopefully continue treating residents in the state. This bill authorizes these licensees to renew, provided they remain enrolled in an approved training program. In addition, the bill prohibits all licensing boards from charging a fee for a temporary license and clarifies the requirements and restrictions related to using terms like doctor, MD, DO, related terms and initials. For implementation, licensing staff are making any necessary process updates to accommodate the optional renewal pathway and informing training programs. Outreach materials related to this physician population will also be updated, and we will include this in the new law roundup. The final bill is Senate Bill 1468, which requires boards that license prescribers to develop informational and educational materials regarding the Drug Enforcement Administration's 3-day rule, which can help get medications to patients to treat a substance use disorder. For this board, we are required to also distribute these materials not only to our licensees, but to California's acute care hospitals on an annual basis. The Department of Consumer Affairs will be providing support on this because this bill impacts multiple boards. We expect the creation and distribution of these materials to happen in the second half of 2025, and again, will be included in the new law roundup. There is no action that we require from the board, no vote on this particular item, but of course staff are happy to take any direction from the board, make any changes or additions to the implementation tasks. With that, Madam President, I'm happy to answer any questions.
That's because my microphone's not on. All right, let me try that one more time. Questions or comments from board members? All right, are there any questions or comments from the public present in the room? All right, let's try WebEx, John.
Yeah, a couple of quick comments, and a phone call came in for me, and I did not have time to write down the exact legislative numbers, but the one on legislation requiring people not to use the term doctor, I think you've gotten a little bit carried away with that. The original case, or one of the cases tried by the California Attorney General, was a woman who had a PhD, nurse practitioner. She had a PhD. She was using the term doctor in her marketing material, and the current Attorney General did sue her. She had to do a fundraising campaign to get the legal fees. Just ridiculous. Another thing I noticed was when you have ADHD, it's totally bogus, but sometimes you're required to take what they call neuropsychological testing. It's total quackery. But when UC San Diego did it for me, or tried to do it for me, I noticed all the people that were doing that claimed to be doctors. None of them were actual medical doctors. Dr. Oz, who I think has been nominated to lead Health and Human Services, something, Medicare or something, he actually sued the board in Pennsylvania or whatever, because they didn't put it on the name. And so I just think that whole thing is just kind of ridiculous. The opening argument against me when I was given a restraining order by a pathological liar who claimed I made threats was I didn't use the polite term doctor. I was just trying to emphasize that I had never met him, that he wasn't my doctor. But that was actually the opening arguments, that I'm dangerously mentally ill because I did not politely use the term doctor. The other one you had on substance use disorder, again, I did not, a phone call came in, I did not really read it, so I'm making some kind of unqualified comments here. But remember, people can just declare that. People can just say you have substance use disorder, especially if they're mental health, and you have nothing you can say about it. Even, I've been reclassified from having ADHD, and now I'm considered to be a depressed substance user. And I don't. So I don't. I'm a teetotaler practically. So just a few quick comments on that. Thank you. That's all I had to say.
Yes, hello. Just wanted to make a comment on behalf of minority patients that the legislation, our hope is that our medical needs are also addressed as an African American population, being such a small minority that physicians see. So thank you very much.
Okay, we'll bring it back to the board. Any comments or questions from board members? We're about to set a medical board record for ending a meeting earlier than normal, which is incredible because we have a full complement of board members for this. All right, any last minute comments or questions? Okay, seeing none, we're going to recess until tomorrow morning at 9 a.m. We'll see you all back here. Enjoy your afternoon.
We're just all extremely docile.